So one of the things we really pride ourselves on, and I think you agree, Neda, is that we are refractive surgeons that offer the entire armamentarium of refractive surgery. So we offer all of the vision correction options. And a common question we often get asked is, how do you determine who's a candidate for what procedure, especially if the patient, anatomically could be a candidate for everything? What is your thought process there?
Yeah, and that happens not that uncommonly, that a patient comes in, obviously their goal is to be out of glasses and contact lenses. And we then evaluate that patient, look at their expectations of surgery, their exam findings, and all of the diagnostics that we do. And there are times, as Arjan was mentioning, that a patient can be a candidate for all three. And it comes down then to really patient preference when that's the case. When all of the anatomical findings really point at all three being safe options for patients, then it comes down to patient preference, what kind of procedure sits well with them, the recovery from the procedure, and cost can be an issue too.
Yeah, I think sometimes an easy way to get a sense for what the patient is feeling is to just take a very broad spectrum approach and say, we have two categories of refractive surgical options. One is an additive procedure, the EVO ICL, where a small implantable lens is added to the front of the eye, and it's reversible in the sense that it could be removed at any time. And we have this other option, a corneal-based option, where the cornea itself is being resculpted or reshaped to permanently confer that vision correction. And then oftentimes, I think just seeing how the patient reacts, that can really help inform the conversation.
And I think more and more patients, the younger generation, really like the idea of reversibility. It is an additive procedure, as Arjan mentioned. It's a contact lens that's implanted in the eye. It's added to the eye. And just as easily, it can be then removed. So it is reversible and really speaks a lot to the younger generation.
So we just kind of discussed when a patient is potentially a candidate for all options, how we have that discussion with patients. Are they a better candidate for laser vision correction or ICL surgery? And how that's really kind of on the patient's desires and their wants. But let's say someone comes in and they're not an ideal candidate for every procedure. There's really three big things we take into account: patient history, patient anatomy, and the refractive error. And we use all three of these to try and guide us to figure out what's the right option for each patient. So maybe now you can talk a little bit about the patient anatomy. I'll start with just what I think of when a patient's coming in. I'm really trying to get to know the patient, trying to figure out what's their profession, what are their hobbies, what are their interests. Because someone who's, let's say, a UFC or MMA fighter, or who plays hockey a lot, or who's maybe prone to getting some trauma to the eyes, they might not be the best candidate for LASIK, where there's a chance of a traumatic LASIK flap being dislodged in the future. They may be a better candidate for PRK or ICL surgery. A patient who is going to have PRK, they need to understand the recovery is a little bit longer. The first week or so, the vision's blurry, it's fluctuating a lot. They might not be quite as functional as they otherwise would be. And so, if they're on summer break, maybe their work schedule allows them to have about a week off or so, they might be a better candidate for PRK, for example. And so I think all of this really, just like with IOL selection, when we're trying to match make the right IOL to the right patient, the history and getting to know the patient is really something I think we take a lot of time in.
There's also other nuances about patient history, such as a strong history of keratoconus or collagen vascular disease, which we consider when we're trying to decide on a corneal-based procedure. Also, any history of dry eyes. Maybe when they came in, dry eye was not an issue, but if dry eye was a significant part of their ocular history, I do consider that and have a conversation about whether corneal-based procedure would be the right option for them. So we touched on patient history as a way to differentiate whether a patient is a great candidate for corneal-based procedures versus an additive procedure such as the EVO ICL. We of course want to touch on patient anatomy as a big part of that assessment of a patient and whether or not they are a candidate for one versus another procedure. As far as the patient anatomy is concerned, the cornea is really the centerpiece of this. We really want to make sure that the cornea is healthy, that the contour allows for corneal-based procedure, if that is what we're considering for the patient and what we're wanting to offer to a patient. Corneal topography and tomography are ways for us to assess the curvature of the cornea, the tear film, the ocular surface. We do epithelial mapping also to look at irregularities that would be beyond the scope of our anterior examination of the eye or even the topography. Epithelial mapping is a great way to really look at the details of the health of the cornea. And sometimes with patients who have form fruste keratoconus, topography could be fully normal, but tomography looking at the posterior elevation or posterior curvature of the cornea or epithelial mapping can hint at risk corneas in these younger patients who may have not yet had a cornea that has evolved to what their endpoint would be. Other anatomical features that we look at, of course, the health of the tear film, the eyelid, is there meibomian gland disease? Is this a patient who may be at risk for developing dry eyes over time? And of course, in those patients, we may veer away from corneal-based procedures if we find that there's enough concern around ocular surface disease and their tear film. We look at pupil size, we look at angle structures, and then of course the rest of the exam to determine if the patient would be a better candidate for one versus another refractive surgical option.
Yeah, I think you made a lot of great points, Neda, and a lot of these issues sometimes can be addressed preoperatively. And so just because a patient has ocular surface disease or has, let's say, a pterygium or a Salzmann's nodule, it doesn't mean that precludes them entirely from maybe a laser vision-based option. If we can address it preoperatively, let's say either with conservative measures or treatment we think that's easy, it's going to be easy for the patient to adhere to even after surgery, then maybe they are a candidate for that. But I think the important thing is to really just do a good thorough exam and we really try to get a sense of the patient's corneal anatomy. Another thing, EBMD, for example, a patient who has EBMD, they're maybe not the best candidate for LASIK or SMILE. There might be a slightly higher chance of suction loss, fluctuating refractive error afterwards. That might be a patient who's a great candidate for PRK because we can treat the EBMD and do a refractive correction at the same time. And so we factor all of those things into play when we're trying to figure out what patient is a candidate for what procedure. But the last sort of big thing we really consider, I think, is what is the patient's refractive error? Neda, I think you gave a great description of the range of correction that the EVO ICL can provide. At a minimum, the patient needs to have a spherical equivalent of at least -3 sphere. You can treat up to -16, so that's fantastic. LASIK, PRK, SMILE, these also have been approved for very high corrections, but I often say just because you can doesn't mean you should, and so we never like to push the margins of safety. LASIK will do up to about -6, -8. PRK likewise can do -4, -6. Beyond that, maybe a slight risk of haze formation. And with SMILE, you can't do hyperopic corrections either. So every procedure sort of has its own limitations, and it's really just a matter of taking account the patient's history, their anatomy, the refractive error, to put all of that together and figure out what's the right option for them.
And of course, the one factor that we didn't really talk about is corneal thickness, and that's really critical when we're considering any kind of corneal-based refractive procedures. With LASIK, PRK, and SMILE, you need to have sufficient corneal thickness because in corneal-based procedures, of course, we are treating the cornea, and so you need to have sufficient corneal thickness to be able to treat the amount of refractive error that there is. And the higher the refractive error, the more flattening that you cause in the cornea, the more ablation you have to perform, and also with SMILE, the larger lenticule that you have to remove. And the higher the refractive correction, the more ablation and therefore higher risk of dry eyes as a result, higher risk of ectasia as a result. And so corneal thickness is a major variable that we consider when we're looking at the anatomy of the eye and deciding which refractive option to offer to the patient.
Yeah, that's a great point. Corneal pachymetry is such an important variable. And we often also take into account not just the primary correction, but especially when we get to moderate to high myopia, we're also looking at, okay, what is the chance the patient's going to potentially experience a little bit of regression over time? And if they do develop a little bit of myopia over time, will there be room to safely do an enhancement? And so that's a great point. Pachymetry is really something that's critical to consider, not just for the immediate procedure, but when we're thinking about the longevity of the results, that also plays into account.